Good evening to everyone, and thank you for joining me on the webinar with the topic New Trends in the Treatment of Gingival Recessions with mucoderm and Emdogain. So first of all, please let me outline the topics of my presentation. So I will go through the different techniques for recession coverage first. Then I will talk about the evidence base for the subepithelial connective tissue grafts. After that, I will talk about the soft tissue substitutes, particularly about the mucoderm matrix, the possible combination of mucoderm and Emdogain. And at the end, I will look at the advantages and disadvantages and summarize the data. For sure, we all have this kind of recessions in our daily practice. So you see single gingival recession, multiple recessions on the vestibular side, but also on the palatal and lingual side. If we take a look at data about the prevalence of gingival recession, we have a study from Safati published in 2010, looking at more than 2,000 subjects. And they showed actually that almost 85% of all these subjects exhibited at least one gingival recession. Most of them had a vertical dimension of 1 to 3 millimeters. Only a couple of them recession depth of equally or deeper than 6 millimeter. And most of these recessions could be attributed to class 1 and 2. Much more often than Miller classes 3 and 4. So we can conclude that the slight gingival recessions are quite common, whereas the deep gingival recession are rarely. So before we start treating our patients, we should identify it and, if possible, remove the etiology. So we should take a look at what caused the gingival recession. Was it due to tooth malpositioning, due to traumatic toothbrushing technique, inflammatory lesions? Was it due to orthodontic tooth movement, abnormal frenal attachment, or was it due to iatrogenic factors like traumatic tooth preparation, impression taking, or some lip or tongue piercings? So here are some of the most common etiological factors. So we have here mechanical factors, iatrogenic factors, but also inflammatory etiologies. So when it comes to the surgical techniques over the decades, numerous techniques were described in the literature. According to Bouchard, we can divide these techniques into 3 groups. So we have the pedicle soft tissue grafts, where we are actually mobilizing soft tissue adjacent to the recession defect and trying to cover with the soft tissue the recession defect. We have the group of the free soft tissue grafts, where we have the submerged grafts and the non-submerged grafts, and we have the group of the additive treatments, where we have the root surface modifiers like EDTA, tetracycline, citric acid or phosphoric acid. We have the use of membranes, Emdogain, acellular dermal matrices, PRP, PRF, and possible combination therapies. So chronologically, when we look at the 70s and the early 80s were dominated by the free gingival grafts, where the focus was on augmenting the zone of keratinized tissue in an apical-coronal direction. You can see here the Bernie-Moulin technique, a 2-stage procedure. So first of all, the zone of keratinized tissue was augmented apical to the gingival recession defect, and in a second surgical procedure, the flap was advanced to the coronal to cover the recession defect. From today's point of view, when aesthetic is becoming more in the focus. The non-submerged graft are not really first choice when treating recession defect. So we know when it comes to aesthetic that the colorimetric integration of the graft is the most important parameter. Further important parameters are the texture match, the volume match, lack of scars, gingival contour. So from today's point of view, the non-submerged grafts are not really recommended anymore. So in the mid of the 80s, the connective tissue graft was introduced to periodontal plastic surgery, and the focus was more on complete root coverage and aesthetic outcome. So here you see a Miller class 2 gingival recession in the lower anterior. You see a harvesting of subepithelial connective tissue graft from the distal palatal aspect. And here the graft was inserted into this pouch, leaving some part of the CTG exposed. You can see the final clinical outcome 10 weeks post-operative in comparison to the baseline clinical situation. So you can see here the coverage of the root surface, but also the thickening of the marginal tissue. So based on the envelope technique, a lot of modifications were performed, like the tunnel technique and the modified tunnel. Here some multiple recessions in the fourth quadrant. You can see the preparation of tunnel and mobilizing the interdental soft tissue, harvesting of the subepithelial connective tissue graft, insertion into the tunnel, and the coronally positioning of the whole complex. Here you see the clinical outcome 3 months post-operative in comparison to the baseline situation. And again, we have a nice amount of root coverage, thickening of the marginal functional tissue, and also some gain of keratinized tissue. And so this is actually where we are now, the modified tunnel in conjunction with the subepithelial connective tissue graft. And we know that the benefits of the connective tissue regarding vascularity, survivability. You can see again here the preparation of the tunnel, insertion of the connective tissue, positioning of the tunnel to the coronal. And here the clinical outcome 6 months post-operative in comparison to the baseline situation. Again, complete root coverage, thickening of the functional marginal tissue, and some gain of keratinized attached tissue. Another case in the lower anterior, you see multiple gingival recession after some orthodontic treatment in this young patient, very thin gingival biotype, and again tunneling of the area, harvesting of the subepithelial connective tissue graft from both sides of the palate, insertion into the tunnel, and the coronal positioning of the whole complex. Here the clinical outcome 3 months post-operative in comparison to the baseline situation. So now we should ask ourselves, why is it that connective tissue graft is so successful? So it's due to its healing characteristics. So a fully submerged connective tissue graft has a double blood supply from the basal side and also from the inner side of the flap. According to this work from Guricha and co-workers from 2001, a fully submerged connective tissue graft is completely vascularized after 14 days. So this is why we have this high early survivability, because we have stable wound healing, and this is why it is so successful. However, a prerequisite for this good clinical outcomes is that the graft is well adapted to the recipient bed. Also, the flap has to be well adapted to the graft. We should take care that there's no hematoma at the interface of the graft and recipient site, and also not between the graft and the flap. And we should avoid any micro movements of the graft complex. So let's take a look at the results following root coverage therapy. So as yet, there are more than 20 systematic reviews and or meta-analysis on the surgical treatment of gingival recession, which were published between 2002 and 2015. And if we summarize the data from these systematic reviews, we can conclude, first of all, that all root coverage procedures can provide significant root coverage for Miller classes 1 and 2. We have also some data for successful coverage of Miller class 3 recession defects. We can also conclude from the literature that the combination of a coronally advanced flap and the subepithelial connective tissue graft appears consistently effective in relation to all clinically efficiency endpoints. So if you're looking at complete root coverage, mean root coverage, gain of keratinized tissue, clinical attachment level, gain a long-term stability, the best clinical results can be obtained with connective tissue graft and the coronally advanced flap. We also know that Emdogain can improve the efficacy of the coronal compared to the coronally advanced flap alone. Or we can also conclude that multiple combinations, like for example the connective tissue graft with Emdogain and a coronally advanced flap, or growth factors with membranes and a coronally advanced flap, usually provide similar or less benefits than the simpler solution. We also know that root surface modifiers really don't provide any adjunctive effect clinically. And as yet, we have also no standardization for the evaluation of aesthetic satisfaction. So we can conclude that at present, for the surgical treatment of gingival recession, the autogenous connective tissue graft is definitely the gold standard. However, if we take a look at patient morbidity, we know that we got used to harvesting connective tissue from one side of the palate or from both sides of the palates. We can go to different locations at the palatum. We can harvest the connective tissue with an epithelial collar or without an epithelial collar. But we also know that we might have some complications. This is also one possibility of harvesting connective tissue by harvesting a free gingival graft and de-epithelializing it outside of the mouth. We also know that the patient's pain perception is associated with the depth of the harvesting of the connective tissue. However, we might also experience some complications. And here a nice case series by Griffin and co-workers published in 2006 showing that after harvesting of connective tissue grafts, nearly 30% of subjects reported moderate to severe pain. Also, almost 35% of the subjects reported moderate to severe swelling. Bleeding was not the problem, but you can see 7.6% of the subjects reported moderate to severe discomfort at the 1-week follow-up. A similar study published by Wessel and Tatakis in 2008 also demonstrated that 50% of subjects where connective tissue graft was harvested reported pain in the palatal donor site, and after 3 weeks, still 33% reported pain in the palatal donor site area. So it's not that it was really heavy pain. You can see here after 3 days on a visual analog scale between 0 and 10, the mean value for pain was about 3.5. However, it's not that it's a complete painless procedure. So it's not surprising that Group 3 of the 10th European Workshop on Periodontology concluded that the limited amount of autologous donors tissue and the increased patient morbidity are substantial disadvantages of the subepithelial connective tissue graft. For this reason, the search for suitable soft tissue substitute is currently in the center of interest of scientists and manufacturers. And just 1 year after this consensus report, Richardson and co-workers published in 2015 this decision tree for the treatment of gingival recession, which is actually the first decision tree taking into the account availability of donor palatal tissue. So here in the situation, Miller class 1 and 2, if you have sufficient donor tissue, okay, first choice would be still the subepithelial connective tissue graft. However, you have also some alternatives like Emdogain combined with a coronally advanced flap, an acellular dermal matrix graft plus coronally advanced flap, xenogenic collagen matrix plus coronally advanced flap. And here you can also have the situation that the patient doesn't want any harvesting of palatal tissue. And here you can offer now some alternatives. Also in the situation, if you don't have enough donor tissue at the palatal side, you can see here, according to this decision tree, first choice are cellular dermal matrix graft plus coronally advanced flap, or animal matrix derivative plus coronally advanced flap, or also a xenogenic collagen matrix. So we have now some alternatives to the autogenous grafts. And now the question is, in which direction are we going? Do we still need autogenous grafts for a recession coverage? So let's take a look at what we have. And the first soft tissue substitute, which was introduced in the mid-90s in the US, was the alloderm. So it is a human dermis. You can see here you have to get rid of the epidermis of the subcutis. The dermis is processed, and what you get is a three-dimensional collagen matrix, which is avascular and acellular. If you take a look at the literature regarding the outcomes of the alloderm, we have here two systematic reviews. The most recent one, here the one from Tatakis and co-workers, published just this year based on the AAP regeneration workshop, and they concluded there is strong evidence to support the use of alloderm in conjunction with the coronally advanced flap as an alternative to autogenous donor tissue. Here we have the systematic review, which was published 1 year before based on the European periodontal workshop, and this systematic review concluded studies adding acellular dermal matrix under a coronally advanced flap showed a large heterogeneity, and reported benefits are not significant compared with the coronally advanced flap alone. So you see some contradictory statements regarding alloderm. However, this shouldn't bother us too much since in all European countries alloderm is not legalized, and it's also not going to be legalized. So we are focusing more and more on acellular dermal matrices of porcine origin. One of these dermal matrices is the mucoderm matrix. The principle is the same as with the human-derived dermal matrices. So you have to get rid of the epidermis of the subcutis. You have to process the dermis, and what you get is intact three-dimensional collagen matrix. So as yet, I gained some experience with this mucoderm matrix, and most of the experience I could gain using it for root recession coverage. However, possibilities are also as a substitute for free gingival graft with GBR procedures, thickening around implants, soft tissue augmentation preprosthetically, or as substitute for free gingival graft in a socket seal procedure. So I will concentrate here in my presentation on the use of the mucoderm matrix for recession coverage. So what are the benefits of this mucoderm matrix? First of all, this is a structurally intact connective tissue matrix. It is completely acellular, also avascular. It's non-immunogenic. It requires a short hydration period, which is good. You can trim it after the rehydration procedure. You can cut it, you can contour it to outline the CEJ. It sticks to the root surface, which is very important to any dead spaces at the interface of the root surface and the mucoderm matrix. You can pull it inside the tunnel, you can suture it, and you have a uniform thickness of the material with a constant quality. The thickness of the material is between 1.2 and 1.7 millimeters. So when we look at the microstructure, you can see here the comparison of the mucoderm matrix on the right side compared to the mucograft on the left side. Here, bilayer structure, very sponges in the inner part, and here a real dermis with a really dense collagen structure. And we studied this microstructure by using a synchrotron-based tomographic imaging. This was published by my coworker, Dr. Papst, just this year. And I want to show you a very short video where you can nicely see this structure. So during the turning of the mucoderm matrix, you can see the preserved collagen fibers and bundles. You can see the preserved vascular channels, and this matrix can be remodeled into existing host tissue. From the results we have seen for the autogenous grafts, so the study by Guica, complete revascularization after 14 days. This is not the case with this acellular dermal matrix. Here the time of revascularization is prolonged, and so this is one of the reasons why this matrix shouldn't be exposed during the early healing period. The next thing we look at in our studies, and this one was published by Dr. Lehmann as the first author, was to look how we can employ a 3D optical system for digital diagnostics, also treatment planning to quantify soft tissue loss. And so our idea was to scan the area of the recession defect to quantify the missing volume. And so we can measure virtually this soft tissue loss, and then we can prepare our 3D collagen matrix. We can combine it with biologics, and it's definitely prepared for the use on the patient. So when it comes to the clinical application, so the most important thing is to ensure excellent vascularization of the overlying flap, which is going to give the nutrition to our dermal matrix graft. And the rules for an optimal flap design for a good blood supply was studied by Merman and Chancho in an angiographic study in 1977, and they concluded in their study that the flaps should be broad enough at their base to include major gingival vessels. The flaps length to width ratio shouldn't exceed 2:1. Buccal releasing incisions will impair the blood supply of the flap. Minimal tension should be produced by suturing techniques, and the tissue should be managed gently during the surgical procedure. And a very important point that partial thickness flap preparations to cover avascular areas should not be too thin, so that more blood vessels are included in them. So this is very important when working with the acellular dermal matrices, because these matrices are avascular, so we need sufficient vascularization of the overlying flap to give nutrition to this matrix. Otherwise, we will have problems with the early wound healing. So these are the rules for an optimal flap design to ensure good blood supply. So let's take a look at some clinical cases. And this one was actually one of my early cases. You can see the preparation of a regularly coronally advanced flap, the rehydrated mucoderm matrix sutured to the periosteum. You can see the healing 2 weeks post-operative and the final clinical outcome 12 weeks post-operative. So you can see some root coverage, you can see some thickening of the marginal tissue. What you can also see is that the matrix is still present here under the alveolar mucosa. So it's still in the process of remodeling. But we should also be aware that we cannot change with these matrices the overlying characteristics of the flap. So if we have overlying alveolar mucosa, we cannot expect that this overlying alveolar mucosa will become keratinized. So there's no induction of keratinization, so no change of the covering epithelium. Another clinical case, in the second quadrant, you can see some white cleft here in this area going all the way through, some deep frenal attachment, and here a modified coronally advanced flap preparation, so a mixed preparation, split full, split thickness. Here the adaptation of the rehydrated matrix. You can see here cutting out the matrix in the area of the cemento-animal junction to ensure that this part is not becoming exposed in the early healing period. You can see the tensionless advancement of the flap and the clinical outcome 12 weeks post-operative in comparison to the baseline situation. Again, you can see the coverage of the root surface, thickening of the marginal tissue. Again, we didn't change the characteristics of the overlying epithelium, but you can see underneath a zone of dense connective tissue, which is giving stability to this area. And another clinical case in the first quadrant, you see multiple gingival recession in this area, and here the preparation again of a modified coronally advanced flap. Again, the mixed preparation split in this area, full in this area, and again split in the apical portion. Here the rehydrated dermal matrix sutured to the recipient side, tensionless advancement of the flap. You can see here the clinical situation 3 months post-operative. You might observe here a small cleft which is at the interface of the mucoderm matrix and the papilla. So there's no need to do any correction in this area, because if you take a look at 18 months post-operative in comparison to the baseline, you don't see anymore the cleft. They will disappear by itself during the remodeling process. You can see sufficient root surface coverage, a nice aesthetic outcome. You can see also thickening of the marginal soft tissue, which is important for long-term stability. But you can see also a nice integration into the surrounding tissue. So from an aesthetic point of view, it would also be judged as a good clinical case. So let's take a look at another technique. You can also combine the mucoderm with the modified tunnel technique. You can see here the inserted rehydrated mucoderm matrix into this tunnel. The 3 months clinical outcome in comparison to the baseline situation. Again, you can see nice root surface coverage, also thickening of the tissue. And this is also what you might observe in some cases that you can see some remnants of the matrix shining through the tissue, especially if you are becoming too thin when splitting your flapper. Is it a problem? I don't think so. You just have to wait and during the remodeling process this will also disappear, so there's no need to do any correction. Another clinical case in the second quadrant, you see multiple recession. Here the preparation of the root surface prior to flap elevation, detoxification with EDTA for 2 minutes, then the preparation of the tunnel, adaptation of the rehydrated dermis. So this is after initial rehydration, after 3 to 4 minutes. Usually I cut it at this point, and after that I rehydrate it for another 4 to 6 minutes, so that it's overall a rehydration time of 10 minutes. You can see here the insertion into the tunnel, one continuous sling suture, and the clinical outcome 3 months post-operative in comparison to the baseline situation. So you can see you can apply different techniques when working with the mucoderm matrix. You can use a regular coronally position flap, a modified coronally position flap, tunnel technique, just as long as you ensure that you have excellent vascularization to the overlying flap, which is going to give nutrition to the matrix. So this is the most important thing. Another point is you have to consider the tunnel technique is technically more complicated. So you might have the situation that you have an exostosis or undercuts. So in these cases, it's easier to raise a flap to have direct visuality to the operating field. So let's talk about complications. I already mentioned that it's mandatory to have a sufficient vascularization to the overlying flap, so you shouldn't thin out the overlying flap too much. You won't have any perforation, and you have also to take care that you don't have any retraction of the flap. Otherwise, the matrix will become exposed and you will lose this tissue. So let's take a look at a couple of complications. Here in this case, you can see here the healing phase after I did tunneling procedure with the mucoderm matrix. There was an exostosis. I split it. The flap over this exostosis had a small perforation, and after that I inserted the matrix inside this tunnel, and you can see here there was not sufficient blood supply to the overlying flap, and some serious wound healing problems. The same was in this clinical situation. You can see that the overlying flap was thinned out too much. You can see a small perforation in this area, a very thick avascular dermal matrix underneath, and now you can imagine that this is not the best prerequisite for optimal wound healing. This is what happened, some serious wound healing problems, and this was the final outcome Also in this clinical situation, I tunneled this area, split thickness in all this area. You can see here the dimensions of the matrix, which is in a vertical dimension too higher, so there's no need to fill out the whole vestibulum with this matrix. But now you can see here the thin flap sutured over this large area of avascular tissue, and this is what might happen. Also some serious wound healing complications. So it's really important to ensure excellent vascularization of the overlying flap, because this is going to give nutrition to the matrix. You should also take care that you don't have any exposure of the matrix in the early healing period, because you're going to lose this tissue in this area. So let's take a look at the quality of attachment following the different root coverage procedures. And there are some case reports with human histology following root coverage procedures. And here are two case reports following the use of alloderm. Both showed no signs of regeneration, so healing was characterized by long junction epithelium and connective tissue adhesion without any signs of regeneration. Also, this case report by Camello and co-workers looking at the histological outcome following the use of xenogenic collagen matrix, also reparative type of healing. We had some signs of regeneration after the use of free gingival grafts and non-resorbable membranes. For the autogenous connective tissue grafts, there are some studies showing regenerations, others not. And we have this study by McGuire and Cochrane from 2003 showing a regeneration following application of animal matrix derivative. So there was some new cementum, periodontal ligament fibers, and also some islands of bone regeneration. So it might be beneficial to combine Emdogain with the mucoderm matrix. So on one side, we have the regenerative capabilities of EMD, and so we might have a beneficial effect at the interface of the mucoderm and the root surface. So we could probably improve the quality of attachment. On the other side, we might also experience a benefit at the interface of the mucoderm matrix and the inner side of the flap. We know that Emdogain improves the early wound healing by stimulating angiogenesis, has anti-inflammatory effects, and so it might compensate for the avascularity of the mucoderm matrix. There are also two studies supporting the combination of an acellular dermal matrix with Emdogain. One was published by Shin and co-workers in 2007, and they actually showed that by combining Emdogain and alloderm, there was an increase in keratinized tissue in comparison to alloderm alone. And another study by Alves and co-workers in 2012 showed that the combination of an acellular dermal matrix graft and Emdogain resulted in better clinical outcomes to the acellular dermal matrix graft alone in smokers. So this is not to look now at the cost effectiveness, but it is really an attempt to improve the outcomes of the mucoderm matrix to come as close as possible to the clinical outcomes of the autogenous tissue. You can see here the combination of the mucoderm matrix and the Emdogain. Unfortunately, it's not possible to soak the mucoderm matrix with the Emdogain intraoperatively because the mucoderm matrix is very dense from its structure, and here the Emdogain gel is not really soaking into this matrix. You have to apply the Emdogain to the root surface and then a little bit between the inner side of the flap and the mucoderm matrix. So let's take a look at some clinical cases. So here you see some moderate gingival recessions in the first quadrant. You see the preconditioning of the root surface with EDTA, again, the mixed preparation, split, full, split thickness. Then the application of the Emdogain to the root surface, the rehydrated matrix is adapted to the recipient side. It's here very important to take care that you don't have any dead spaces between the mucoderm matrix and the recipient side. You see the tensionless advancement of the flap to the coronal, the 6 weeks postoperative healing outcome, and the 3 months postoperative outcome, and the comparison 3 months postoperative to the baseline clinical situation. Let's take a look on some other cases combining the mucoderm matrix with Emdogain. Here, some multiple gingival recession in the lower anterior in a young patient following orthodontic treatment. Here you see very thin gingival biotype. Again, the mixed preparation, split, full, and again split thickness preparation. Especially here in the lower anterior, you have to take care that you have no muscle pull in this area. Otherwise, you will have retraction of the flap, exposure of the mucoderm matrix, and everything which is exposed will get lost over time. You can see here the Emdogain on the root surface, the adaptation of the mucoderm matrix. You can see here the differences between this side and this one. So you have to take care that it's nicely adapted to the root surface. You have to avoid any dead spaces. For example, like in this area, you see the coronally positioning of the flap and the 12 weeks healing outcome in comparison to the baseline situation. You see some nice wound healing, significant coverage of the root surface, but also a nice thickening of the marginal functional tissue, which is important for the long-term stability. Another case in the second quadrant, you see a multiple recession on tooth 2-1, 2-2, and the canine. Again, modified coronally advanced flap preparation, split, full, and again split thickness with one vertical releasing incision distal to the canine. You can see the Emdogain application to the root surface. You can see here the adaptation of the rehydrated mucoderm matrix. Again, you can see here the newer cases where I cut out the area here at the collar to outline the cemento-animal junction so that I don't have any exposure in the early healing period. You might apply some Emdogain on the mucoderm matrix. And you can see here the tensionless advancement of the flap. You can see the view from the occlusal side to see that it is properly closed. And you can see the early healing period, 4 weeks post-operative. Again, you might see this cleft where the mucoderm meets the papilla. However, already after 8 weeks, you can see that this cleft is not so is not visible as it's here after 4 weeks, just due to the remodeling process. You can see here the clinical situation 10 weeks post-operative, at the left side 3 months post-operative, and here 9 months post-operative, and you can see the outcome 9 months post-operative in comparison to the baseline situation. And you can see here in this case complete root coverage, also thickening of the functional marginal tissue, also some gain of keratinized tissue if you compare here this area to this area, also here and also in the canine region. Another case, same patient in the first quadrant. You can see here thin gingival biotype, no attached keratinized tissue left in this area. You can see the outline of the flap. Again, a mixed preparation, split here in this area, then full thickness, and again split thickness. You can see the, oh, I'm sorry for this. Again, the application of Emdogain and the dermal matrix. You can see here the clinical situation 6 weeks post-operative and 6 months post-operative in comparison to the baseline situation. In this case, you can see also some thickening of the tissue, sufficient root surface coverage. Here, the amount of keratinized tissue which we gained is not much more than we had here baseline. However, again, we have a dense zone of connective tissue beneath this flap, which will give stability to this area. Another clinical case, multiple recessions in the upper jaw from canine to canine. You see some deep abrasion defects with some class 5 fillings. We removed these fillings. You can see again the preparation of a modified coronally advanced flap with tunneling of the anterior papilla. You can see again application of Emdogain to the root surface, rehydration of the matrix, and adaptation to the recipient side. Coronally advancement of the flap. Here you can see the early healing period and the outcome 14 weeks post-operative in comparison to the baseline situation. And if we go to the same patient in the lower anterior, again, here some deep abrasion defects, class 3 recession defects. Here minimal amount of keratinized tissue in this area. You can see the tunneling of this area. Application of Emdogain to the root surfaces. You can see here the preparation of the mucoderm. Again, this is not properly rehydrated. You can see this here, this whitish area. So this is not fully rehydrated. But usually after 3 to 4 minutes, I take it out. I prepare it. I cut it. And then I rehydrate it for another 5 to 6 minutes so that it's overall about 10 minutes. You can see here the properly rehydrated mucoderm inserted into the tunnel. You might apply some Emdogain between the mucoderm and the inner side of the flap. You can see here the coronally advancement of the tunneled area. And here the outcome clinically 3 months post-operative in comparison to the baseline situation. So you can see here these were Miller class 3 recession defects. If you can see here, if you take a look here at the canine baseline 3 months post-operative lateral incisor, baseline post-operative central incisor, is baseline post-operative, also the lateral incisor and the canine. So it's not a complete root coverage, but nice clinical outcome for this clinical situation, and you can see some thickening of the tissue. So if we summarize what are the criteria for predictable results when working with the mucoderm matrix and also in combination with Emdogain, so you should prefer a microsurgical approach. You already saw that you can apply different techniques, but most often it's between the decision between a modified coronally advanced flap or the tunnel technique, whereas the tunnel technique is more technique sensitive than the modified coronally advanced flap. You should take care about proper rehydration of the matrix. The dermal matrix has to be covered 100%, and you have to take care that you don't have any exposure in the early healing period. The rehydrated matrix has to be closely adapted to the recipient site. There shouldn't be any dead spaces at the interface root surface to the rehydrated matrix. Very important, the wound stability in the early healing period. And you should maintain a proper brushing technique post-operatively. So it's definitely technique sensitive, the work with the acellular dermal matrices. You don't have the forgiving effect as you have it with the autogenous connective tissue grafts. So you will definitely experience a learning curve when working with the soft tissue substitutes. However, when you compare the advantages with the disadvantages, you have much more advantages. So you have no tissue harvesting anymore from the palate, thus less post-operative complications, a reduced surgery time, a reduced risk during the surgery. You have unlimited availability of the tissue with a constant quality, and thus it's a very patient-friendly approach. So you can cover recessions, let's say the upper jaw in one session and the lower jaw in one session. There's no need to cover it by sextants or quadrants. What are the disadvantages? As yet, we don't know the exact percentage of shrinkage during the remodeling time. We know that it's a technique-sensitive procedure without any forgiving effect as we know it with the autogenous connective tissue graft. And we have also to consider the costs for the material. So let me summarize my lecture. So the collagen matrices definitely provide a safe and a reliable option to the subepithelial connective tissue grafts for surgical root coverage. When you're looking at the data, it seems that the add of the connective tissue graft may improve the efficacy of the coronally advanced flap. Actually, the clinical outcomes are coming close to those reported for the autogenous connective tissue grafts. Here in this systematic review by Cambodone and Tatakis, the subepithelial connective tissue grafts performed 8.9% better regarding the mean recession coverage in comparison to the collagen matrix plus the coronally advanced flap. So here we are very close. The add of Emdogain may further improve the clinical outcomes of the collagen matrices. So this combination of mucoderm and Emdogain is an attempt to come as close as possible to the clinical outcomes following autogenous connective tissue grafts. On this other side, we need good randomized controlled clinical trials to assess the efficacy of the collagen matrix in combination with the coronally advanced flap. Also the combination of the collagen matrix with Emdogain and the coronally advanced flap, and the comparison with the gold standard, which is the coronally advanced flap with the connective tissue graft. So let me thank you very much for your attention, and please feel free to send me an email under kasaj@gmx.de, and I will be more than happy to answer your questions. Thank you very much.